Thank you, David. You've heard very clear and concise presentations by outstanding researchers on a variety of new potential therapies for both ulcerative colitis and Crohn's disease. And I do want to try and put this in perspective as to what we've learned about where we're at now and where we're potentially going with these new agents. If I can have my first slide up, please. There we go. So where are we currently with therapies? We are currently utilizing therapies according to two different aspects, both the severity of the disease, and I'll come back to that in a minute, and how patients have responded to prior treatments. So for first-line therapies, we're using aminosalicylates and budesonide, aminosalicylates typically for maintenance therapy, primarily in ulcerative colitis. And I've kind of blended these here, not to be specific on any of these agents. For more moderate to severe disease or patients who have not responded to first-line therapies is when we have typically invoked corticosteroids, and as many of us have alluded to, steroids tend to be a game changer in these diseases. In Crohn's disease, it really tells us that the patients are going to have a bad prognosis, with approximately 40% of patients with Crohn's disease going to surgery within a year of starting corticosteroids, at least in a population study. Once patients are treated with steroids, aminosalicylates are not as effective at ulcerative colitis and maintenance, and we usually move on to immunomodulatory therapies with either the thiopurines or methotrexate. And then for patients who fail steroid induction or fail maintenance with immunomodulators is where we are currently positioning the biologic therapies, either anti-TNF or anti-integrin therapies. And then usually, as you heard from Jean-Fred, the biologics are continued on a long-term basis. So what's new and where are we going to put these? So what have we learned? We've learned that IBD is chronic and progressive. The symptoms do not reflect the inflammatory burden, and you heard Bill just mention that the FDA is now going to require not just patient-reported outcomes of symptoms, but also evidence of endoscopic healing in both ulcerative colitis and Crohn's disease. We've learned that treating to biologic targets, such as mucosal healing, improves longer-term outcomes. I'm going to show you again and again that the earlier we treat in these diseases, the better, that it's important to get the most out of our initial therapeutic responses, and then that pharmacokinetics and pharmacodynamics are going to really make a difference with both our current and new therapies. You've seen this 1,000 times. But Crohn's is a progressive disease where the symptoms do not necessarily reflect the transmural damage to the bowel. Put this into a population series of patients where there is progression from primarily inflammatory disease to these fibrostenotic or fistulizing disease over months and years. And where are we going to make the biggest impact on the outcomes of the patient? There is a progression of the disease more rapidly in some individuals than others, but we're going to make a bigger difference if we treat early before patients have the structural damage than if we treat late. And what a consistent message is with all of the new therapies and the therapies that you've heard is that they are late therapies. None of the therapies that were presented except Mongerson was actually utilized in early disease. Does this make a difference? Yes. We've seen with a variety of different agents, the earlier the better, and you're seeing week 26 and 52 response with adalimumab according to disease duration. The longer the disease duration, the less absolute benefit the patients are going to achieve. We've seen with all of our biologic agents, the anti-TNFs, that there is a gradual loss of response during continuous regulated maintenance therapy. And this is where therapeutic monitoring is going to come into play, how we can modify that. And that's to the point that 50% of patients who start on infliximab are already off it by the end of the year. And It's very similar for adalimumab, as this comparative study by Mark Osterman suggested, that 50% of patients at half a year have already discontinued either infliximab or adalimumab. So we have to make these drugs, make our drugs work better. How can we do that? We've consistently messaged to you over the past several years about therapeutic drug monitoring, and we know that at the end of an induction phase with either infliximab or adalimumab, that is going to portend the response in maintenance, that patients who have adequate levels at the end of the induction are going to do better in maintenance therapy. We've seen that in the ulcerative colitis studies and also in ACCENT-1, where patients who have better drug levels at the end of induction do better long term. This also applies to the newer therapies with vedolizumab. Unexpectedly, higher drug levels, and it's unexpected because we have a target, as Brian described, which are the receptor saturation, but despite that, higher drug levels have been correlated with better ultimate responses. We've also learned that the first hit is the best. We've seen this in all of the studies with the different agents. With adalimumab, with anti-TNF naive patients, and these are two different trials. They don't really allow direct comparison, but we get the impression that patients treated with their first TNF are going to do better than patients treated with their subsequent or third anti-TNF agent. So the first hit is going to be our best opportunity. Likewise with vedolizumab, we look at patients who are anti-TNF naive versus those who had lost response to TNFs. The earlier the better, and the patients who had not received anti-TNFs did better. They also had a shorter duration of disease. We've seen that in ulcerative colitis and also in Crohn's disease, that the patients who were previously exposed to TNF they did well, but not as well as the patients who had not yet been treated with biologic agents. So I just want to review the indications for our current biologic agents. And it all began in 1998 with infliximab, and I'm not being totally comprehensive in this, but as you can see, all of the agents, and it's somewhat of a cut and paste indications. And the reason is, since 1998, when the FDA was concerned about the safety of the first biologic agent, which was infliximab, initially the patient population was restricted to individuals who had not responded to conventional agents, salicylates, steroids, and/or immunomodulatory agents. And with each subsequent biologic, that has been the patient population that has been studied. And we get up to natalizumab, it's even one step further. Moderate to severe disease, not responding to conventional agents and anti-TNFs. And the current indications for vedolizumab are moderate to severe, either ulcerative colitis or Crohn's disease, not responding to conventional agents or anti-TNFs. It's come to the point now that the duration of the disease in clinical trials is averaging 6 to 10 years in patients with Crohn's disease before they're administered these novel agents. Well, where is that going to place these individuals who have failed multiple agents, who are now on their 6th to 10th year of disease, as far as their likelihood to respond because of the underlying either structural damage or refractoriness to prior treatments? So what are we seeing from these next generation therapies? They've been administered in late disease, 8 to 10 years, in patients with complicated disease, many of whom already have some evidence of structural damage or fistula. Many of the patients, 40% or so, are steroid refractory and have gone through numerous drugs and they've been resistant. In the clinical trials, we have not adequately utilized pharmacokinetics and pharmacodynamics to optimize treatment. And one of the ubiquitous problems we actually have outside of the integrant potential for integrant therapy is an absence of biomarkers that are going to predict responses. Now, the only trial I'm actually going to show that was shown by Bruce earlier is the study on ustekinumab to really identify a couple of factors. There were two ustekinumab trials, one in patients who were refractory to conventional agents and had not had, for the most part, TNF agents, and they had an average duration of disease of 6 years, whereas the patients who had failed anti-TNF agents in Unity 1 had a disease duration on average of 10 years. I want to emphasize, and this is my thinking at the moment, ustekinumab is a primary therapy, monotherapy for psoriasis. It's indicated as a first-line treatment for psoriasis. And where are we going to end up seeing this positioned in Crohn's disease? For patients failing A, B, C, D, and E after 6 to 10 years. So a patient with bad psoriasis can get ustekinumab right off the bat, and we're going to have to wait, according to third-party payers eventually, for patients to fail multiple therapies in order to get an effective therapy. The other thing that we've learned about these is that when we treat patients earlier and primarily before corticosteroids, we markedly reduce the side effect profile. So here's a potential first-line agent for Crohn's disease, but we're not going to be able to administer it because we haven't positioned it correctly in these controlled trials. And again, there's about a 20% difference in the less refractory patients compared to the patients who failed multiple agents, including anti-TNF. So how are we going to improve the initial response to biologics? We need to treat patients earlier in the course before complications. We need to ensure that they have a complete response. We need to utilize combination therapy with certain agents where immunogenicity is a greater issue, and utilize both pharmacokinetic and pharmacodynamic aspects of these drugs to optimize the treatment along with therapeutic drug monitoring. So to compare our current efficacy and our current gaps, with aminosalicylates, we can use them early in mild to moderate disease. They have both the inductive and maintenance benefits. They're generally safe. They're about 50% effective in inducing long-term remissions and relatively cost-effective. Our gaps are efficacy in Crohn's disease, patients with more severe disease, the current pill burden, the rectal applications in combination oral and topical therapy, the other side of the coin of lack of efficacy in half the population, and the potential relative costs, which may be modified eventually by generics. Now, corticosteroids are the drugs we love to hate. They are effective in moderate to severe disease. They are effective early or late in the disease. And steroids are the rescue therapy for everything. Patients who lose response to TNFs, steroids are a rescue therapy. Patients who don't respond or lose response to vedolizumab, steroids are a rescue therapy. They have about 80% efficacy in controlling symptoms of patients, and their major attribute is, of course, their low cost. But the gaps are safety, safety, safety. A second thing that we haven't really thought a great deal about is this concept of steroid dependency. Without Dan present in the audience or up here at the speaker's table, someone has to advocate against steroids because they may actually make the disease worse or at least more refractory to other therapies. And because of these attributes, we don't like to use steroids as a maintenance treatment. The immunomodulators may be steroid sparing and used in combination with biologics, but their efficacy alone as a steroid-sparing agent is only about 40%. They're cost-effective, but their gaps include the induction, There's safety issues that Bruce has alluded to overall, and we would certainly like to improve their efficacy. We can do that with more potent immunosuppressives, such as cyclosporin, but then we're up against the worse safety profile. So where are we with the anti-TNFs? They've currently been indicated essentially for late disease, defined as moderate to severe after conventional agents, which leaves us with complicated disease. And when we look at the clinical trials, I don't think this reflects necessarily clinical practice, but in clinical trials, there's 30% steroid-free remission with most of the anti-TNFs. Given alone, they are relatively safe, and far safer than corticosteroids. But the issue is cost, cost, and cost. And I've often said, if anti-TNFs cost $1, we'd be using them in everyone. It's the cost that is driving the late-stage utilization. So our opportunities are early disease as first-line therapy before complications. We are learning and continue to learn how to enhance their efficacy with therapeutic drug monitoring. It would be nice to get rid of the parenteral formulations, and the cost is going to be reduced, as we discussed yesterday, with biosimilars. As far as the antiintegrants, they're currently positioned very late. Again, for moderate to severe disease, the efficacy in the range of 30 to 40% long-term. They appear to be safe, as we've heard, but again, the cost is the driving factor for their late utilization. We have better opportunities in early disease for patients with mild to moderate rather than moderate to severe. We would like to improve their onset of action, and that may be a difficulty with their current mechanism of action, that they may not work as fast as some of the other biologics, such as anti-TNFs. And we would love to have, again, non-parenteral or oral delivery systems. And we certainly are going to need to improve the cost structure if we're going to be giving these to more and more patients. So what are our current indications and consequences? They've been limited to moderate to severe disease and patients not responding. The consequences are more patients with steroid refractory and steroid dependency, and these are patients who have none of the benefits and all of the risks. It's given to patients with long duration disease who are the least likely patients to respond because of refractoriness and the pre-existing transmural complications in long duration Crohn's disease. And what we've seen from all of the studies that my colleagues have presented is less than 50% remission rate for these next generation therapies. So one of the problems is our current definitions of disease, and we've been looking at that because the FDA has gotten rid of the Crohn's Disease Activity Index. We've stated for the past years that symptoms don't necessarily reflect the underlying biology of the disease, and we need to consider redefining the disease activity in patients, and then we may be able to reallocate patients. We've been talking about patients or giving therapy according to the risk or to the prognosis of patients having bad disease. And ultimately, we're going to need to assign patients according to the prognosis rather than their symptoms alone. So what are our needs? The needs are for treatment of early disease rather than the late phase disease that we're going to see at the end of the algorithm that I showed you. We need both enhanced inductive and maintenance benefits as well as biomarkers that are going to be helpful in identifying which of these biologic or more targeted approaches that we're going to use. Clearly, we need more cost effectiveness. But we also need improved development pathways. As I've shown you, since 1998, the patients going into the clinical trials of biologic agents have had to fail conventional agents and more often anti-TNF biologics as well. We need to work with the regulators as well as industry to target earlier disease in patients with perhaps more mild to moderate patients who might have a bad prognosis. But of course, this is limited by patient availability. And I was intrigued as I walked into the conference center of the number of companies that are trying to enroll patients now into clinical trials. This is a big issue. Brian Fagan, who leads Robarts, has to look all around the world to identify a small number of patients who are acceptable into the clinical trials. And these are patients who are non-responding. What we really need are trials earlier in the course of the disease if we are going to ultimately modify the disease in a larger population. So what are the near-term expectations? At the moment, we're continuing this late disease development. We're seeing marginal improvements in efficacy due to this patient population. And we are seeing a potential game changer. The only drug that was described that was used relatively earlier was Mondrison, as Bill Sanborn described. But we don't have a great deal of confidence yet because they primarily treated to symptoms rather than endoscopy. And Bill identified an important point that endoscopic evidence of improvement is going to be greatly needed. But if drugs such as Mondrison are safe and effective, these may be game changers in the future. But I have to leave us at the present time for a slide that I've shown well now from more than 20 years from Sir William Osler, that I always use the newest medicines first before their effectiveness wears off. Thank you.